So we shall discuss about INI SS 2025, which actually, in fact, 24 is conducted in the March. So if you take the question this time, actually, there are really very few questions came from neurology. In fact, majority of the super specialities carried less number of questions. But when I had discussed with students, there had been some question came from the environment, the poisons, then from the gastro, a lot of questions came. It was totally different from the previous pattern. And one problem which faced by the students was that uh, there was three parts, A, B, and C. You have to answer the initial 50 questions in the A initial, then you have to go to B, and then you have to go to C. Once you finish the A, then you go to B, you cannot go back to A. So what happened was majority of the candidates in the first part, they got the lengthy questions and tough questions. So they didn't get time to complete the first part. Then second part and third part are one-liners, which was easy to answer. So they had a lot of time in the third part. Specifically, this is what I got my input I got from my students. So many of them face problem with the first part of the exam. So this was the new thing was introduced to prevent the piracy. So what happened was in the first part became more tougher. So we'll go to the questions of NEET neurology part. We got around 15 questions. Some of the options, if I'm going to tell you that it may not be the exact option, some of them we don't know exactly what was given. So I'm not dividing it into the chapter wise because there are only 13-14 questions. First question is, which is among the following is true about Parkinsonism? Early onset symmetry was the first option. Stagnant onset and gradual increase, that was given as B and C. I'm not sure which was this was actually it was there. Asymmetrical motor symptoms early onset levodopa induced dyskinesia. Whatever be the option, we'll go and try to answer it, because I am not sure this was exact options given or not, because I was confusion with the stagnant onset and gradual increase, whether it was in a single option or as a separate options. Anyway, early onset symmetry is not a feature of classical idiopathic Parkinson's. Classical idiopathic Parkinson's, it is asymmetrical onset is a classical, not symmetry. So that is not true. And the last option, the early onset levodopa induced dyskinesia, this is also not true, because this is a classical feature which you see in MSA, multi-system atrophy, which we have discussed. Perioral dyskinesia, very common with Parkinsonism, that is not typical for atypical IPD. The question was not about Parkinson's. I think the question was about IPD. I'm not sure about the exact pattern of question, but this is a probable question. So the answer is actually early onset symmetry is not a feature of typical IPD or idiopathic Parkinson's, it's a feature of actually atypical Parkinson's. So the answer was early onset motor asymmetry. So asymmetry is something which is true about the IPD or idiopathic Parkinson's. So that was that question. So going to the next question. This was actually an interesting question. If it may looks very tricky, but it is very easy to answer if you use some common sense. The maximum risk for ischemic thrombosis for stroke in which of the following? Antithrombin 3 deficiency, factor V Leiden deficiency, protein S deficiency, APLS syndrome. This may look tougher, but actually, if you just remove your stress and just think among the option below which has arterial and venous stroke, as simple as that. So basically, all those things, all these protein C, protein S, factor V Leiden, antithrombin, everything is related to venous thrombosis. But for APLS syndrome, even the inclusion of this syndrome includes arterial plus venous stroke. So that itself tells you that APLS syndrome is one of the most common cause among the these disorders which causes stroke. Rather than antithrombin, factor V, or protein C or protein S, they causes predominantly venous thrombosis. So the answer here is APLS syndrome, because APL is one thing which is causes arterial plus venous stroke, and others are predominantly venous stroke, but they also add on as a risk for arterial stroke also. So APLS syndrome, even if you take the inclusion for the APLA, that tells venous plus arterial. If you use that common sense, the answer is APLS syndrome. So we'll go to the next question. That's actually a weird question. Like, I'm not sure whether they ask cancer related neuropathy or chemotherapy induced neuropathy. Whatever, if it is a cancer related neuropathy, this can be either a compression, paraneoplastic neuropathies, or because of infiltration. I don't know what all options are given. A cancer related neuropathy, like any other neuropathies, gabapentin is one thing which is approved, duloxetine is approved. So among the option, I think gabapentin was the best option, but we will discuss about a cancer related neuropathy and chemotherapy related neuropathies. Chemotherapy-related neuropathy, you remember Bo V. Platt. Bo V. Platt, that is bortezomib, vincristine, platinum compounds, and taxanes. This is a common cause for chemotherapy-related neuropathies, where duloxetine, where these chemotherapy-related neuropathies, duloxetine and gabapentin, these two are used. Cancer-related neuropathy can be tumor invasion, paraneoplastic neuropathies, radiation-induced neuropathies, and nutrition deficiencies. So, if it is a tumor invasion, sometimes you have to give steroids, you may have to do a surgery, or even compression, you may have to do a surgery. A paraneoplastic neuropathy, steroids will work. So, I'm not sure what was exactly the option given and what was the exact question. But if you take all together as a cancer-associated neuropathies, you combine both chemotherapy-related and cancer-related neuropathies combined together. You take it as cancer-associated neuropathies. The drug of choice which is approved is one is gabapentin. So I think that was the answer for that. I'm not sure about this answer and this question. I'm not 100% sure about this. I inquired many of the students. They also not sure what was the option given and what was the question there. So this is what I have to discuss here. So just remember this one, Bowie Platt. That can be obvious question next time also. And I think that your oncology faculty also may have discussed about this question. He might have a better idea sometimes about the question. So we'll go to the next question. This also looks very tricky question. Unilateral headache, osmophobia, phonophobia, photophobia, kinetophobia, all those things were given. Some told only sonophobia are there, but some of the students told me that there was kinetophobia given. So if you see those scenarios, take those things, it looks very complicated, but it is actually easy. If you go back to the options, SUNCT, paroxysmal migraine, cluster headache, all these are trigeminal autonomic cephalalgias. So trigeminal autonomic cephalalgias, these osmophobia, sonophobia, photophobia, these are not that common. That can occur, but these are not that common. So among the option given, this is actually a migraine. This is what I feel about this question. And unilateral headache, sonophobia, osmophobia, photophobia, and kinetophobia, I feel the answer is migraine. Migraine can cause kinetophobia. Migraine classically cause photophobia and phonophobia. But other TAC usually can cause some photophobia and these things, but they usually doesn't present with kinetophobia and unilateral syndromes with these much sonophobia, osmophobia. These all things can occur in migraine because the pathogenesis of migraine is so different from trigeminal autonomic cephalalgias. So that was the answer for that question. We'll go to the fourth question. This was also some interesting question. Actually, very easy again. If you don't complicate it, don't think too much in NEET. Unlike INI, NESS, for NEET, don't think too much. These questions are actually direct questions, but they will try to make it more complicated by keeping you some images or something. They want to divert your attention. So they are given a picture of adenoma sebaceum, that is classical for tuberous sclerosis. Then they ask a question: what is the drug of choice? So drug of choice of seizure and tuberous sclerosis I had discussed in our module. It is vigabatrin. Vigabatrin, visual side effects, GABA transaminase inhibitor. So the answer is vigabatrin. So that was as simple as that. If you pick up that, it is adenoma sebaceum. So this is again one more question. Just looks interesting, but actually it's easy. They had given some students told that they had given eye finding with telangiectasia also. Plus there are some SW and T2 images are there. It almost like this is what I got. There are multiple hypodensities seen in the SW. So the question was, which among the following is the answer for this? Cerebral telangiectasia, Far's disease, cerebral iron deposition, cavernous angioma. So I think this was the exact question and option just kept. So if you take it, if you go into the confusion comes between cerebral telangiectasia and cerebral angioma. So if you take cavernous angioma. So if you take cerebral telangiectasia, actually these are the small vessel malformation. They don't press. They usually have this vessel malformation, which will be seen black in SWA, like your cavernoma. But in between there will be normal brain tissue. But in here you see inside this malformation there is no normal brain tissue. So this is actually a cavernous angioma. So I'll show you the picture of CNS telangiectasia. I will show you a picture. This is CNS telangiectasia. You can see that this is the SW image showing a telangiectasia. You can see the normal brain tissues in between that. It is not that much altered like this image. So that is the answer is cerebral cavernous angioma is answer or cavernoma is answer. So telangiectasias are small, low flow vascular lesions of dilated capillaries are intercepted with normal brain parenchyma. Okay, so answer was that. This is also, even the question again makes you more confused, but if you think very straightforward clinically, you can answer it. HIV patient on stavudine develops appendicular sensory loss, that is limb sensory loss, areflexia, and increased lactate. So you will just debate the question. Leave the stavudine part. You take this part. Develop appendicular, the limb sensory loss with areflex. What does that mean? LMN syndrome. LMN sensory syndrome. It is an LMN sensory syndrome. This much is clear, right? Then you go to the option. Myelopathy can be present, but myelopathy, why areflexia? So myelopathy is unlikely. Myelopathy will present with UMN findings. This is predominantly areflexia, global areflexia with sensory loss and appendicular limb. It is a peripheral neuropathy. So neuromuscular disorder is also out because it is neuromuscular is a motor disorder. It is not a pure motor. This is a pure sensory disorder. So the confusion comes between toxic neuropathy and HIV neuropathy. There is a catch. They're given stavudine. So stavudine, there is increased lactate. So stavudine causes peripheral neuropathy and stavudine causes mitochondrial dysfunction that causes increased lactate. So the answer is toxic neuropathy because of stavudine. If that lactate was not there, that can still be an HIV associated neuropathy or nutritional neuropathies. But as lactate they are mentioned elevated, that means the stavudine causes mitochondrial failure. That stavudine toxicity is causing mitochondrial failure, causing increased lactate. So that is a toxic neuropathy. So the answer is very easy. You dissect the question and find out the answer. So stavudine is an NRTA, a dose-dependent mitochondrial toxicity, axonal neuropathy, lactic acidosis because of mitochondrial toxicity. So they can also cause myopathy and hepatic steatosis. But here the question, they are given lactate, stavudine. These are the catch, which tells you it is a LMN syndrome, sensory syndrome with stavudine, and there is an acidosis. The answer is nothing but a toxic neuropathy. So this is the same slide which we are discussing the infection, where you discuss some MCQs in infection, where I had covered all the infections. Almost every neuro infection is covered there. So please make sure that you go through your 10 MCQs there, because that contain more knowledge or more concept. Plenty of areas are covered in that. Many of the questions asked in this also comes from that MCQ part. So you can see the ATT drugs side effects, distal asymmetric polyneuropathy, D drugs, the stavudine, the 4D, diadenosine and salcitabine. They begin within few months. This is classical sensory neuropathy. Okay, secondary because of toxic, because lactate was elevated. Again, another interesting question. Many students got confused in this. There is nothing much to confuse in this question. You see, a low vitamin B12 value was given in the question. I don't know whether it was exact value was given or not, but anyway, there's a low vitamin B12, and they're given us history of progressive memory loss, executive dysfunction, and distal areflexia, ataxia, and brisk knee jerk. I'm not sure whether brisk knee jerk was given or not, but anyway, there's a distal areflexia, sensory symptom with a progressive episodic and memory loss, episodic memory loss and executive dysfunction. So you think it is a dementia and low B12. There is no doubt it is a B12 deficiency. B12 deficiency produces subacute combined degeneration. B12 deficiency causes dementia which mimic Alzheimer's. We had a patient when I was doing my DM. He is coming from near Trivandrum. From there is an area where all the Brahmins live. He's a Brahmin who is actually Ayurvedic practitioner, not a local, like he does Natu Vaidya. So what happened is he came to us with similar symptoms. He had been treated in some other hospital, but when we examined, he had an acute pigmentation also. His B12 was too low. He had typical Alzheimer-like phenomenology, but we had given him B12. After 2 months, he was completely fine. So that the answer is B12 deficiency with subacute combined degeneration, because subacute combined degeneration is the reason for brisk knee jerk, ataxia, areflexia, progressive memory loss, and executive dysfunctions because of the low B12 affecting the brain. It is not Alzheimer's with incident B12 deficiency. Alzheimer's with incident B12 deficiency is a rare possibility. But I had told you multiple times in the module, whenever in dementia, the main thing of dementia is to find out those with treatable dementia. So this is a treatable dementia. The answer is B12 deficiency with subacute. If somebody asks me whether the Alzheimer's, the first question is correct or not, that is also obviously correct. Alzheimer patient, if they develop long-standing B12 deficiency, they can have subacute combined degeneration, true. But Out of the two, the common thing and treatable thing is B12 deficiency with subacute combined degeneration. They can present with memory disturbance. They can present with subacute combined degeneration. The answer is doc. Okay, so the answer is B12 deficiency with subacute combined degeneration. Again, a very easy question. They are given some image like this and identify the image. This is nothing but MR spectroscopy. This is a very one-liner answer. If ever once in a while you have seen an MRS during your entire MD lifetime, even if you have seen one image of MRS, you will be able to answer this. This is an MRS. 60-year-old with fever, headache, CSF protein 120, raised, and sugars is 50, somewhat reduced. I don't know whether they are given a cell count. I don't know whether they are given the RBS value. Anyway, this is a fever, headache. That means a possible meningitis with a CSF protein raised with low sugar. You think of bacterial meningitis. Fine. So what drug will you give? Ceftriaxone plus vancomycin, ceftriaxone, gentamicin, ampicillin, ceftriaxone, vancomycin. Very easy. Something which I have told multiple times during the modules. The patient with less than 2 years or more than 50 years, you should consider the possibility of adding ampicillin. Okay, so that the answer is ampicillin plus ceftriaxone plus vancomycin because the organism Listeria comes there. You see, you remove the neonates. It is basically the bacteria which is located in the mother's perineum. That is Enterobacteriaceae, Agalactiaceae, Listeria, and more than 50 years it is Listeria, and less than 2 years also. Otherwise, it is Streptococcus pneumonia plus H influenza. So, pneumonia plus meningitis. So, you have to cover ceftriaxone plus vancomycin normally in all the empirical treatment, but for those less than 2 years, more than 50 years, or those immunocompromised, consider treating Listeria by adding ampicillin. The dose is 2 gram IV Q4H. Okay. So more than 50 years, you have to add ampicillin. Otherwise, you have third generation cephalosporin plus vancomycin. So the answer here is ampicillin, vancomycin. That is very easy question. You might have answered it. Again, this is looks complicated but easy. Almost similar image. I'm not sure whether this is the exact image. Low CD4 count, HIV positive, fever, meningitis, issue, and they are given some MRI which shows some ring enhancing lesion, some lesions in the brain. Using the location is in the basal ganglia. This is the internal capsule. This is a caudate nucleus, and this is a lentiform nucleus. So here there are some lesions located in the basal ganglia. So whenever an HIV patient with a basal ganglia lesion, you will suspect the first diagnosis is not TB, it is toxoplasma. So low CD4 or any patient with HIV positive, there is a ring enhancing lesion which is located in the basal ganglia. First DD should be toxoplasma. Clear? And you can, if you see clearly, you can see that there is some central hypodensity and surrounding hyperintensity. There, I'm not sure whether target sign was kept or not, but anyway, even if without that, the location tells you that the first possibility is a toxoplasma. So this is something which we have discussed in our module. I mean, this is again from the MCQ part of infection. CMV, PML, Cryptococcus, toxoplasma. So I'm not sure what exactly the CD4 count, what any other link, any other thing extra has been given, whether MRS value is given or whether CSF findings is given. I'm not sure. So from the available thing, what I think, if it is a basal ganglia in HIV patient low CD4, first thing is toxoplasma. Clear? This is a really interesting question. A female patient relapsing remitting MS, positive Lermit sign. That is very important in this question. Low JC virus, wants future pregnancy. What is the most appropriate drug? I have discussed in our module. The drug of choice of MS in pregnancy is injectable, particularly glatiramer and interferons. So glatiramer is less effective, interferons is now preferred. But interferons is a weaker drug. So here in the option, if you see interferon gamma is there, what we use interferon beta, not gamma. So it is not interferon. First thing, the answer is not interferon in this answer because what they are given is interferon gamma, not interferon beta. The drug is interferon beta. Again, they are told that positive Lermits and relapsing remitting. That means the patient is having active disease. Positive Lermits means posterior column involvement and active disease is there, most likely to be an active disease. So when you have an active disease and low JC virus, another hint. So about fingolimod is teratogenic, should be avoided in pregnancy. Interferon beta can be given, glatiramer can be given, teriflunomide, notorious for your teratogenesis, so it should be avoided. So this should be avoided, this should be avoided. So the answer is actually natalizumab. Natalizumab is not 100% safe, but those with high activity and low JC virus in pregnancy, you still can give natalizumab. I'll show you the article. So most safest is glatiramet. Then interferon beta can be given as the newer data shows lower risk, but the option that is interferon gamma is what they are given. So that is not the option. So DMD's potential to continue until or close of consumption. First line is injectable medication interferon beta and glatiramer. It can be continued. Okay, safe. Dimethyl fumarate, high risk, can be continued is what they are telling, but practically I am not given dimethyl fumarate. I used to shift to interferon beta, and it can even continue till the just before the time of consumption because they can be removed very fast. That is one use. Natalizumab can be continued until consumption in these cases, and women should plan to continue during pregnancy. Those who plan to continue during pregnancy can be continued if there is a high risk for relapse. You can still continue natalizumab during the pregnancy, provided the JC virus load is less. So that is what, again, rituximab, it is not absolutely contraindicated. Rituximab can be given, but rituximab is associated with high risk of abortions and preterm delivery. So that is why among the available option, if it is interferon gamma, then you can go with natalizumab because again low JC virus load. So this was actually an interesting question. Now coming to the next question, MRI image was given. What is it? This is actually, we have discussed in the module in embryology part. I have discussed all the images there. Porencephaly, lesioncephaly, schizencephaly, everything has been, holoporencephaly, everything has been discussed. So this image was exactly almost similar image. You can see there is no sulk, no gyre. It is very smooth brain. This is absence of gyre, that is known as lesioncephaly. Lesioncephaly, pachygyria syndrome, which we have discussed in our module, which is lesioncephaly 1, which is classically the images there is no gyre. It is very smooth brain. That is same image given there. Though this answer is lesioncephaly. So what is schizencephaly? Schizencephaly is a cleft which is extending inside, cleft lined by gray matter extending inside the ventricle. That is schizencephaly. Then porencephaly, we have discussed the module. If you want to read much more, know more about that, watch the embryology module where I have discussed in question answers about holoporencephaly, semi-lobar holoporencephaly. So porencephaly is where you don't have much abnormality in the cortex. It is basically the lobulation abnormalities. So the answers here are lesioncephaly. They're actually a pediatric neurology question. So now coming to the next question, a rapidly progressive ILD with dermatomyositis. So ILD with dermatomyositis, again, we have discussed this multiple times in our module. You see, there are the dermatomyositis antibodies. They can be anti-MI2, which was a classical dermatomyositis with moderate involvement of the muscle and more involvement of the skin. NXP2, mild to moderate muscle and classic rash. If you see anti-MDA5 associated rapidly progressive ILD. So the answer here is a rapidly progressive ILD is associated with MDA5 antibody association. So the answer here is MAD5 or M. I think it was actually MDA5. Just given it the wrong way, not MAD. It is MDA5. Anti-MI2 is associated with classical skin and less muscle. That is another option there. The importance of TIF1 gamma is strongest association with malignancies. Also, same thing we have discussed. Again, ILD can be associated with anti-synthetase syndrome, not with dermatomyositis, anti-synthetase syndrome. Muscle disease plus ILD. That can be anti-Jo1, PL7 and PL12 antibodies. And a severe lung disease associated with PL12 with no muscle. Muscle and ILD, Jo1 and P7. But the question was dermatomyositis. So the answer is MDA5. Okay. This is another antibody that we have discussed, HMG-CoA related necrotizing myopathies. You go to the module on inflammatory myopathies. Everything is there. There is one hot topic in all the entrance, inflammatory myopathies. So this was a really tricky question. A image-based question with patient macrocephaly and dystonia. This is actually again a pediatric neurology question. Actually, you can dissect this in two ways. First method is you take the history, macrocephaly, dystonia. I don't know what extra is given. And the option contains actually all organic acidemias. The question was among the organic acidemia, which one causes macrocephaly and dystonia? You don't need the image for this if you know that part. So Macrocephalic dystonia and organic acidemia is classically seen in glutaric acidemia. So the answer is glutaric acidemia if you approach in that way. If you don't know about that, then you take the MRI and then trying to go through the MRI. MRI actually, I don't know whether exactly this was image. It was showing some white matter relations. So it's a leukodystrophy. So another way you can approach is which among the following acidemia, aciduria, acidemia produces present with leukodystrophy. The leukodystrophy with organic acidemia is the most common cause is glutaric aciduria. So again, in that way also you can answer that. Okay, so I'll just tell about different acidemias. Glutaric acidemia type 1, that is the most common cause of organic acidemia producing leukodystrophy. They present with the macrocephalic dystonia, encephalopathy, especially after illness and fasting. So child after illness or fasting, progressive worsening neurodeficit with macrocephaly and dystonia, you think of glutaric acidemia. Propionic acidemia, vomiting, lethargy, hypotonia, hyperammonemia, and metabolic acidosis. So metabolic acidosis is core for all acidemia, all organic acidemias. Methyl malonyl acidemia, same as propionic acidemia. Then isovaleric, sweetie food odor. This is something which is interesting, which can be potential question. Isovaleric acidemia causes sweetie feet odor. Then maple syrup disease. Then multiple carboxylase is a biotin responsive where you have skin rashes, alopecia, ataxia. Otherwise, almost all acidemias present with hypotonia. They present with seizures and encephalopathies, and blood shows increased pH. So hypotonia is a core feature, but glutaric acidemia is where you can get a dystonia plus macrocephaly. So you can dissect that question in two ways: either a leukodystrophy with acidemia or those with macrocephaly and dystonia with acidemia. The answer is glutaric acidemia. I don't know what extra was given in the question. So organic acid with leukodystrophy, it can be type 1 glutaric aciduria. Acidemia is the most common cause where they have leukodystrophy. Then L2 and D2 hydroxyglutaric acidemia also can, rarely. 3-methyl glutamic acidemia and methyl malonic acidemia, propionic, all these can cause, but the most common is type 1 glutaric acidemia. And again, macrocephaly and dystonia, others causes hypotonia, lethargy, seizures, encephalopathy. But this is one acidemia which produces present with macrocephaly and dystonia. So that was a number of questions which asked in our module. So what we have for the question pattern this time is, all the questions were a little bit, neurology are only few questions, unlike other time, the number of questions in neurology, cardiology were very less. And most of the questions are actually not at plain DM level, but it is answerable if you use some common sense. If you take the options, you dissect it, it will be easy to answer. They may try to confuse you with a figure, they may confuse you with some other clues. They want you to get trapped in that clue. So just be calm and approach such questions. Don't get tense to such questions. And the pattern in the new type of pattern where you have 3 parts, part 1, part 2, and part 3, 50, 50, 50. Sometimes, like this time, the first part has a large number of questions. You get tensed. If you get tensed, the second part and third part, you will make mistakes. So even if you don't get much time in the first part, be calm to approach the second part. You have to attend this pattern of question paper as a 3 separate exams. Otherwise, you will not get time, because the first 50 questions, if you answer, if you close it, then go to session B, you don't have a chance to go back to the part 1. Part 1, you finish, you go back and revise and see the question, then close it, then go to part 2, answer it before the time closes, then finish it, go to part 3. So take it as 3 questions, and in between there is no gap. Consider it as a 3 paper. That's all. Thank you. Thank you so much.